You're treating the smoke, but the fire is burning somewhere else entirely. And I know that because I've spent 20 years sitting across from men just like you, reviewing their lab results, watching the same look on their faces. Their cholesterol looks mostly okay. Their blood pressure is managed. They're doing what their doctor told them to do. And yet, there it is on the scan. Plaque growing. Silently narrowing the arteries that keep your heart alive. I've had patients come to me after seeing 3 different cardiologists. All 3 said essentially the same thing. Lower your fat, take your statin. Come back in 6 months. Every 6 months they came back and the plaque kept progressing. Not because they weren't listening, because the advice was addressing the wrong thing entirely. If you've ever been told to just eat less fat, take a statin, and check your numbers once a year, this video is going to feel like someone finally turned the lights on, because everything you've been taught about arterial plaque is probably wrong. Not slightly off, fundamentally wrong at the biological level. I'm Dr. Kevin O'Wale. I'm a cardiologist. For 2 decades, I've been watching the standard approach fail the exact men who followed it most faithfully. Today, I'm going to show you what plaque actually is, what builds it, and what a specific daily nutrition protocol does to begin reversing it down to the molecular level. Stay with me. Every block of this video matters because each one only makes sense after the last. And there is something in the middle of this video, a specific biological deadlock that changes everything about how you understand this problem. So, you think the problem is cholesterol. I get it. That's what we've all been told. High cholesterol means fat in the pipes. Pipes get clogged, heart attack follows. Simple, satisfying story. Almost entirely misleading. Here's what's actually happening inside your arteries. Plaque is not fat accumulating like grease in a drain pipe. Plaque is an immune response. Your body is not being careless. It's trying to protect you. And that distinction changes everything about how you approach the solution. When the inner lining of your artery, a single cell thick layer called the endothelium, becomes irritated and inflamed, your immune system responds the way it always does. White blood cells called macrophages rush in to address the damage. They're supposed to clean things up and leave. But here's where the story turns. If the LDL cholesterol in your bloodstream has been oxidized, chemically damaged, those macrophages consume it. They eat and eat far beyond their normal capacity until they become what researchers call foam cells. Bloated, dysfunctional, unable to perform their original cleanup role, and they get stuck there inside the arterial wall. Those foam cells pile up, recruit more immune activity, trigger inflammatory cytokines, and over time they harden with calcium. What you end up with is a plaque lesion, a raised, calcified, inflamed mass embedded inside the wall of your artery, not fat in a pipe, an immune catastrophe playing out in slow motion over decades. Here's the number that should stop you cold. Studies estimate that the oxidation of LDL cholesterol is the rate-limiting step in this entire process. Without oxidation, the cascade largely doesn't happen. Macrophages pass right by healthy LDL. They consume damaged LDL. Oxidized LDL is the trigger, not LDL itself. So, the real question was never how much cholesterol you have. It was always how oxidized is your cholesterol. And why is your arterial lining inflamed in the first place? But this process doesn't start on its own. It's triggered by something completely ordinary in your kitchen or your bathroom cabinet. And once I name them, you're going to realize you've been living with the enemy in plain sight. Suspect number 1, refined seed oils. Sunflower, corn, soybean, canola. Polyunsaturated fats that are chemically unstable at their molecular structure. When you heat them, and you heat them every single time you cook, they undergo a process called lipid peroxidation. They oxidize. Those oxidized lipids enter your bloodstream and directly damage your LDL particles exactly the way I just described. That bottle of vegetable oil sitting next to your stove is not a neutral cooking medium. It is an oxidation delivery system and is built into virtually every restaurant kitchen and processed food on the market. Suspect number 2, and this one genuinely surprises my patients, the low-fat doctrine itself. 40 years of fat is the enemy has led most men over 45 to cut saturated fat, avoid red meat, and lean heavily on carbohydrates and processed low-fat products instead. Here's what that actually does to your blood. It lowers your HDL, your so-called good cholesterol. And HDL is not just a passive number on a lab report. HDL actively patrols your bloodstream, picks up damaged LDL particles before macrophages can consume them, and physically transports cholesterol away from arterial walls back to the liver for clearance. This process is called reverse cholesterol transport, and it is one of your body's primary defense mechanisms against plaque. When you chronically lower fat intake, your HDL drops, your triglycerides rise, and your remaining LDL particles become smaller and denser, the most oxidation-prone form. You've disarmed the cleanup crew and left more vulnerable particles in circulation. Research now suggests the low-fat diet in many cases actively worsened the underlying arterial biology rather than protecting it. And suspect number 3, the one nobody sees coming, your mouthwash. Bear with me, because this is published biochemistry. Your body converts dietary nitrates from vegetables into nitric oxide. Nitric oxide is one of the most powerful vasodilatory molecules your body produces. It relaxes the smooth muscle cells inside your arterial walls, increases their elasticity, reduces stiffness, and directly fights the endothelial inflammation that starts the plaque cascade in the first place. But this conversion doesn't primarily happen in your stomach or liver. It happens in your mouth. Specific bacterial strains on your tongue. Bacteria that belong there reduce dietary nitrates into nitrites, then into nitric oxide. They are a critical part of your cardiovascular biology. An antibacterial mouthwash, the regular kind most people use twice a day without a second thought, eliminates those bacteria. Studies show that people who use mouthwash regularly have measurably higher blood pressure, significantly lower nitric oxide production, and greater arterial stiffness compared to those who don't. You are rinsing away a biological system that was protecting your heart every single morning. 3 ordinary things: refined cooking oils, low-fat eating habits, antibacterial mouthwash, working together quietly every single day to accelerate exactly the biological process that builds plaque. Now, you're thinking, fine, I'll just stop doing all of that. Problem solved. But it's too late for that alone. And this is where I need your full attention, because what I'm about to describe is the reason that simply eating better hits a wall. A literal biological wall. Once foam cells accumulate in your arterial walls, they become biologically trapped. The mechanism that would normally allow cells to eject stored cholesterol, a protein called ABCA1. The reverse cholesterol transporter gets progressively downregulated inside foam cells. The more foam cells you accumulate, the less your cells can hear the signal to release what they've stored. The cellular receptors desensitize, the transport machinery slows. It's as if the exit door gets bricked up from the inside and calcium begins to bind to the plaque, hardening it layer by layer. The protein responsible for preventing this matrix gab protein, or MGP, is what your body normally uses to pull calcium out of arterial tissue and route it to bone where it belongs. But MGP requires activation by a specific nutritional co-actor to function. Without it, MGP stays in its inactive form and calcium keeps depositing year by year until the plaque becomes structurally rigid. So even if you eliminate every source of oxidative stress starting today, the existing plaque has its own defensive biology. The foam cells can't eject their stored cholesterol. The calcium keeps hardening what's already there. The inflammatory environment self-perpetuates. You're pushing against a biological deadlock. And the standard toolkit, reduce fat, take a statin, exercise more, does not have a mechanism for unlocking it. Statins do what they do: reduce new LDL production. They are not designed to reverse existing plaque biology. We don't need another restriction. We need a key, not a drug, a specific combination of bioactive compounds that work directly on the molecular mechanisms of plaque, targeting each step in the chain I've just walked you through. The foundation is raw Arugula and raw beets. Both are exceptionally high in dietary nitrates. When the oral bacteria, the ones we're protecting by stopping the mouthwash, process these nitrates, they produce nitric oxide. Nitric oxide signals the smooth muscle cells inside your arterial walls to relax. It reduces the endothelial inflammation that starts the plaque cascade. It improves what clinicians call flow-mediated dilation, the ability of your vessels to respond, expand, and adapt to changing blood flow demands. Studies have shown that regular high-nitrate vegetable intake can reduce systolic blood pressure by 8 to 10 points in people with arterial stiffness. That is not a marginal effect. That is clinically meaningful, measurable, and reproducible. A generous handful of raw arugula and half a small raw beet every day. Not occasionally, daily. Because nitric oxide has a half-life measured in seconds to minutes and requires constant dietary replenishment to maintain arterial benefit. Next, high phenolic extra virgin olive oil. And I want to be precise because regular olive oil, even the good-looking bottles at the supermarket, will not do what I'm describing. You need oil with the phenolic content above 250 mg per kilogram. The specific compound you're looking for is oleoanthol. Oleoanthol has been demonstrated in peer-reviewed research to upregulate the ABCA1 transporter. The exact protein I said gets bricked up inside foam cells. It forces that exit door back open. It signals foam cells to resume ejecting their stored cholesterol back into the bloodstream where HDL can carry it to the liver for clearance. The mechanism has been replicated in multiple laboratory and clinical contexts, and it requires roughly 3 tablespoons of qualifying oil per day. Drizzled cold over your salad, never heated, because heat above 40 degrees C begins to degrade the phenolic compounds that make this work. Dark glass bottle kept away from direct light and heat. And here is your quality test. If it doesn't produce a mild, distinctive peppery burn at the back of your throat when you taste a small amount from a spoon, that sensation is your oleoanthol. The oil does not have sufficient phenolic content. Put it back. Third, pomegranate seeds. The active compounds here are pinosins and elagitanins, among the most potent documented inhibitors of LDL oxidation in the nutritional literature. Remember, oxidized LDL is the original trigger for the entire cascade. If LDL particles arrive at your endothelium in an undamaged, non-oxidized state, macrophages largely ignore them. It's only the damaged particles that trigger foam cell formation. Punic agents appear to bind to LDL particles directly, coating them and shielding them from oxidative attack. Research published in Cardiology and Atherosclerosis journals has shown that regular pomegranate consumption can reduce the oxidative susceptibility of LDL by up to 30% in high-risk populations. Some studies in populations with established coronary disease have shown figures even higher. 84 cup of fresh pomegranate seeds added to the salad daily. Fresh seeds, not commercial bottled juice. Processing significantly degrades the punic allergens, and most commercial juices contain added sugar that creates its own metabolic problem. Seeds only. And the fourth element is the one my patients consistently find most surprising: vitamin K2, not K1. That's a different compound found in leafy greens, primarily involved in blood clotting. K2 specifically, the form called MK7, is the activator of MGP, the matrix GL protein responsible for clearing calcium from arterial walls and directing it to bone where it belongs. Without adequate K2, MGP remains in its inactive form and calcium deposition in arterial plaque continues unchecked. With consistent K2 intake, MGP activates and begins removing calcium from existing arterial calcification, routing it to skeletal tissue. The best food sources for MK7 are natto, fermented soybeans, consumed regularly in Japan, which has among the lowest rates of arterial calcification mortality in the developed world, and aged Gouda cheese, which has unusually high K2 content due to its specific fermentation process. You need 45 to 90 micrograms of K2 daily for consistent MGP activation. 2 to 3 slices of aged Gouda or a small portion of natto several times per week alongside the daily salad protocol gives you what you need. Now the critical mistake I see every single time without exception. People hear daily protocol and their brain translates it to weekdays. Discipline Monday through Friday, and then the weekend happens. A dinner out, a trip, a family event. Here's what you need to understand about the biochemistry. Inconsistency doesn't give you 70% of the benefit. It resets it. Nitric oxide is metabolized within seconds to minutes. Oleoantal's upregulation of ABCA1 is transient. It peaks around 4 to 6 hours post-consumption and requires daily signaling to maintain the effect. Pomegranate's LDL oxidation protection requires consistent circulating levels of punic halogens. 5 days on, 2 days off does not produce 70% of the outcome. It produces a fraction of it because the mechanisms require sustained uninterrupted signaling to produce lasting structural change in your arterial biology. This is daily medicine taken in food form. Every day is not a lifestyle preference. It is the mechanism. And stop using antibacterial mouthwash entirely, permanently, not occasionally. The oral microbiome you need for nitrate conversion takes weeks to properly re-establish after disruption. Brush well, floss thoroughly. Use a tongue scraper. Your oral hygiene does not depend on killing the bacteria that protect your cardiovascular system. By day 7, most men notice something subtle but real, a shift in morning energy, not dramatic but distinct. This is the nitric oxide effect becoming consistent across a full week. Blood is moving more freely through peripheral vessels, delivering oxygen more efficiently to muscle and brain, and the body registers that as something different from the baseline fatigue that had become normalized. By day 21, something more significant shifts. Inflammatory markers, if you're tracking them, start to move. CRP, the C-reactive protein that flags systemic inflammation, begins trending downward. The oxidative environment continuously damaging LDL particles and feeding the foam cell process is being interrupted upstream. Some men at this stage report resting blood pressure readings measurably lower than they've seen in years. Not because a medication changed, because the arterial biology changed. By day 60, the real molecular work is compounding. ABCA1 transporters in foam cells are being consistently upregulated. Cells that accumulated cholesterol for years are beginning to release it. MGP activation is clearing calcium from arterial tissue. The plaque is not dissolving overnight. The reversal is gradual, but the environment that built it is being systematically dismantled at every step of the cascade. This is the window where advanced lipid testing begins to tell a genuinely different story. And I want to be clear about what to measure because this is where most men are looking in the wrong place. Your total cholesterol number means almost nothing in isolation. What matters is your oxidized LDL level, your Lp(a), your small dense LDL particle count, and your ApoB ratio. These reflect what's actually happening inside your arterial walls, not just how much cholesterol is in circulation, but what kind and how damaged it is. Ask your doctor specifically for an oxidized LDL panel and an advanced lipid particle analysis. Most are available. Most doctors can order them, and most men have never been offered them because they're not part of the standard annual panel. They should be by day 90. The men who stay consistent report something I find difficult to describe in purely clinical language. A shift. The chronic fatigue that had become their assumed baseline reduced the low-level heaviness they'd accepted as normal aging easing. Physical stamina improving in ways they hadn't expected. And when they do a coronary artery calcium score CT scan, a non-invasive low-radiation imaging test that gives you an actual quantitative number for your calcified plaque burden, some begin to see what we call progression arrest. The score stops climbing. In men who catch this early, regression begins. Here is what I want you to carry with you when you close this video. You came into this video thinking about cholesterol, about a number on a lab report, about a pipe getting clogged with fat and a drug to slow it down. That's the smoke. You were managing the smoke with statins, with low-fat food labels, with annual blood draws, while the fire kept burning underneath. The oxidation, the endothelial inflammation, the foam cell accumulation, the calcium deposition, the systematic suppression of ABCA1 and MGP. The fire doesn't care about your total cholesterol number. It cares about whether your LDL is oxidized, whether your endothelium is inflamed, whether your foam cells can eject what they've accumulated, whether your MGP protein is active and removing calcium from tissue that should stay soft and elastic. And now you have a specific mechanistically grounded, biochemically precise protocol that addresses each of those processes. Not a supplement brand, not a drug, not a restriction. Food daily, precisely chosen for what each compound does at the molecular level inside your arterial wall. Arugula and Beets for nitric oxide production and endothelial protection. High phenolic extra virgin olive oil for ABS-A1 upregulation and foam cell reversal. Pomegranate seeds for LDL oxidation prevention upstream. Vitamin K2 for MGP activation and calcium clearance from arterial tissue. 4 ingredients, 4 mechanisms. 1 daily meal that functions as targeted biological intervention. But having the right protocol also means knowing how to measure whether it's working. And the tool that most men never hear about in a standard cardiology appointment is the one that actually shows you the inside of your arteries in real terms. Not an estimate from a blood ratio, not a risk percentage, a score. A specific number that tells you exactly how much calcified plaque is present in your coronary arteries right now and how it changes over time. In the next video, I'm going to show you exactly what a coronary artery calcium score is, how to request one from your doctor, how to interpret your result against the reference range for your age, and what your specific score means for your actual risk level. Because knowing you're doing the right things is one thing, but seeing the objective evidence in your own imaging is something else entirely. It is, in my experience, the moment that changes behavior permanently. If you've watched this far, you already understand more about your arterial biology than most people will ever have explained to them.